thin tangential slices, 3 tangential slices around one axis, and these tomograms were applied for maxillary sinuses in sagittal plane and in coronal plane. But once again, I would like to highlight that definitely in developed countries, these radiographs are replaced by cone beam CT. And this is a condyle, mandibular condyle, and 4 tomograms obtained at different angles in relation to long axis of the condylar head. And as mentioned, we still take these radiographs. So this is a radiograph of just TMJs, but this is the right side. This is the left side, and if you pay attention, you will see the difference, because in this image, the condyle is in the glenoid fossa, so mouth is closed, and in this case, the condyle is on top of articular eminence, so the mouth is open. So that's the right side, this is the left side, and in fact, such radiographs are a kind of a functional radiographs, because they show the difference between maximum mouth closing and maximum mouth opening. And these radiographs are quite useful in everyday practice. So we will have a look at more of them next year when we have lectures in dental radiology. That's another example of the same kind of tomography. So we've got closed mouth position, open mouth position. So the glenoid fossa is empty because the condyle is on top of alveolar process. Left side alveolar eminence, and the condyle is on top of articular eminence. And this is again closed mouth position. This is the glenoid fossa and the condyle inside the glenoid fossa. And this is also one of the cases of mouth fully closed and fully open. And you can see that in this patient, the mouth opening is very important, because the condyle traverses to the front anteriorly in relation to articular eminence. Okay, so before we move on to panoramic radiography, I would like to close for a moment this presentation. And what I would like to show you now is a short film about taking bite-wing radiographs, but using a panoramic machine. So this is also a kind of tomographic imaging. And now let me share the screen with a film. Hopefully it's going to run smoothly. It's just not the film I wanted to launch first. I wanted to show you first the bite-wing film, but the other one was launched. Okay, now it's going to be the right one. 1 second. Okay, I'm sharing again. Okay, I'm sorry, but I had to restart my computer. Can you please tell me when you stopped to hear or see anything?
We watched all of the video, it just didn't have sound.
It didn't have sound. Oh, yeah. I'm sorry. I shared it with sound. Okay, hopefully the next video will be shared with sound, but something was wrong and I had to turn off my computer and restart it completely. Okay, so it was a video about how to take bite wings in a panoramic radiograph, but hopefully the next video will be running more smoothly because the next one will be even more important about panoramic radiography. So now for a moment, we are coming back to the slides presentation. And I would like to go on with panoramic radiography. So, of course, this is a very broad topic. So, this year we learn about radiography, so how to take x-rays. In the first year you learned about radiological anatomy, so a little bit ahead of radiography, what you can see in the radiographs. And finally next year you will be learning about radiology, so what's abnormal in these radiographs. And only learning these three parts, so you will be able to diagnose what's visible in panoramic radiograph. As far as the technology is concerned, in contemporary panoramic machines, tomographic movement principle is applied, and this is rotational tomography. And in fact, the idea for rotational tomography first appeared in Poland because it was a medical radiologist, Ernest Matuszko, before the World War II, who constructed a device for taking rotational tomograms, but unfortunately he did not publish his results before World War II. And as you might know, Poland was very much affected by World War II, and after the war, the works on rotational tomography were started by another researcher in Finland, whose surname was Padero, and he is worldwide accepted as the so-called father of panoramic radiography. So in general, the basic principle for panoramic radiography is the same since the beginning of the 1950s. So the rotation of the X-ray tube and the image sensor in opposite directions around patient's head. But owing to computers, owing to robotic movements of the so-called C-arms, the tomographic movement becomes more and more complicated, and therefore the obtained images are more and more accurate. In these first radiographs, the tomographic layer was more narrow in anterior jaw and thicker in posterior jaw. So altogether, the whole mandible, the whole maxilla would fit in the radiographic tomographic plane. And this is a schematic drawing of this focal plane. And we can compare the panoramic radiograph like film stretched on the curved maxillofacial area of the patient. In the newest devices, like the devices that we have got in our departments, new technologies are applied in relation to registration of the images because digital sensors are used, and owing to that, instead of one thick slice, up to 20 thin slices are registered during rotation of the X-ray tube. And then it's the task of a software based, of course, also on AI currently. And the software chooses the sharpest parts of the radiographic image and decides which of the squares in which of the 20 images is the most clear, is the most sharp, and should be used in the reconstruction of a final radiograph. So I'm not sure if last year you had a chance to have some classes with Dr. Kasia, probably no, but she did her PhD last year, and unfortunately following the PhD defense she quit. So this year we are not going to have classes with her, but still I'm using some material from her PhD because it was a very good study. So as you can see here, Kasia, she created a kind of a phantom of human mandible with plaster mixed with grains of rice to mimic the structure of a bone. And she placed human teeth, of course, after having obtained the permission from the local bioethical committee. The teeth extracted for various clinical indications. And then she took radiographs in panoramic machines in correct position and in incorrect position. And with this option of the software choosing the best squares, the radiographs were always in focus, always very clear. You can have a look at this clipper. And in those which were incorrectly positioned and not using this technology, the images were not clearly visible. And another panoramic machine that we have got in our department, it also offers choice of layer in radiography, but this time this is not automatic. This one is based on manual scrolling through the images in a selected region of interest. So a doctor wants to see, for example, upper first molar, and you know that these teeth usually have 3 roots and may have 3 to 4 root canals. And in order to see them separately, the doctor scrolls in the image. So, for example, in this side, you can see the mesial-buccal roots clearly, but the palatal root is not very well visible. But if you scroll towards her hard palate side, you can see the palatal root with periodontal ligament space, but not the buccal roots in focus. And now, talking about panoramic radiography, I would like to highlight that the development of technology in this field is just tremendous when you compare old radiographs with the new ones. So the old ones are like, you can see here, this faded, torn wallpaper, and the newest ones are like a very fancy designer wallpaper. So this is a panoramic radiograph taken about 20 years ago. So the quality is definitely inferior. It's difficult to see bony structure in posterior mandible because of the overlap of the shadow of contralateral side of the mandible. Then there is an overlap from the shadow of a cervical spine, so it's not possible to see anterior teeth at all. The radiograph is yellowish because of film processing. And finally, the markers demonstrating the side of the radiograph were placed too far to the front in the cassette, the metallic cassette for with intensifying screens for the conventional films. So this marker, which is like D, if you know French, it's D for droite, so the right. It produced ghost image on the other side of the radiograph, and this one, I think it must have been gauche, like left in French, and then someone added L like left in English and lewy in Polish. And these two metallic letters, they produced a very big ghost shadow cast on the image of contralateral angle of a mandible. So we really have traveled a very, very, very long way in technology of panoramic radiography. So this one is extremely clear and I'm sure much nicer for interpretation than the previous one. But I wouldn't be too happy because with these thin slices, we on the other hand miss some detail because of a lesion, a foreign body, a plate for osteosynthesis and surgery. If they are outside this thin focal plane, they might not be visible in the resultant radiograph at all. So sometimes we miss lesions because the radiographs are just too precise. And now let's have a look at positioning for panoramic radiography. So when you invite a patient for panoramic radiography, you of course first have to check the patient's credentials, then ask if it's a female. If a female is not pregnant, technically speaking, I read an article about male being pregnant in Italy right now, but it was a female who changed gender, but before the final step, before the removal, surgical excision of a uterus, it turned out that he or she was pregnant. So now there was a male pregnant in Italy, and quite a dilemma for the local authorities what to do about this. So anyway, you have to verify patient's credentials. If it's a digital radiograph, you input all the data on the computer. If it's a PACS system, the data will be imported from registration system. And you have to tell your patient to prepare for the scan. So we ask the patient to remove everything which is removable from the head and neck. So what can you remove? Necklace, earrings, piercings, then removable prosthetic appliances, removable orthodontic appliances, glasses, hearing aids. But what is fixed has to stay, like fixed braces, fixed prosthetic appliances, any surgical clips, any surgical plates, any prostheses like TMJ prostheses, dental implants, etc., etc. And during positioning, we ask the patient to step into the machine. In some machines, the patient will be seated, but there are no panoramic radiographs that I would know in which the patients are being scanned when lying down on the radiographic table. So we ask the patient to stand in the machine and take like half a step forward so that the patient has a kind of sensation of falling to the back. That's why we ask the patient to hold the handles to support himself, herself. And then we have got the laser lights. In this machine, there are 3 laser lights. The first one is for symmetry. The second one is for the Frankfurt plane, so for horizontal position of the occlusal plane. And the third line that you can see here, it falls between lateral incisor and upper canine. And this one is for the choice of a focal plane. And in the dentulous patients, it should fall around the canthus of the mouth. And yes, and these are the lines that you check. So this is the line for symmetry, and please remember that the line has to fall between the teeth, the upper incisors, and do not look at the soft tissues of the nose because your patients may be asymmetric in soft tissues, but you need to have a symmetry of the dental arches. Of course, again, Some patients will not be symmetrical because this is the type of a skeleton of this patient, but in general, pay attention at teeth, not at the soft tissues. The second line is the line that we can see very clearly in here, but this is a line that goes between external auditory meatus and infraorbital rim, and it should be horizontal. And I would say that with time, with experience, you don't really need that line because you just see when the occlusal plane is flat, like parallel to the ground. And the third line is mentioned, and you assess the first two lines standing in front of a patient. So here you can see a little bit of a second line, sorry. But you assess the third line when you stand aside. So not in front of a patient, but you stand aside. And in some newest machines, technology goes even further. So instead of assessing the lines, you assess the image of patient's head, which is projected on the screen from two cameras, one in front of the patient, one at the side of the patient. And when the position of the head is okay, the machine shows you green light. But if the head is tilted in the wrong direction, or the chin is up, the chin is down too much, the image on screen will be flashing red, so you will know that there is something wrong about it. And if you ask me personally, it's much easier to take a panoramic radiograph than to take an intraoral radiograph. And I do hope that now everything will be working, because again, I would like to show you another little film about panoramic radiography. This time just about the panoramic radiography. Just give me a second because I lost all the videos that I had opened for you, because the restart of my computer. And yeah, I need okay. I need to Google it again. I will show you the films for the device that we have got in our department. It's our newest panoramic machine. So it will be a short film about standards panoramic, hopefully. And now I will go to the share modes again. I'm sharing the sound from the computer, so hopefully it will be running without problems with this time.
To begin, prepare the imaging software until the computer screen says, "Waiting for ready." The appearance of this screen may vary depending on your software and version. If imaging in Plan Mecha Romexis, follow the steps below. Open Plan Mecha Romexis. Select the appropriate patient. Select 2D module from the menu on the left, or choose Go to 2D Imaging from Next Steps located on the bottom left of the patient dashboard. Select Panoramic Exposure from the 2D Imaging dashboard or from the top drop-down menu. Once computers show "Waiting for ready," walk over to the touch pan on the Plan Mecha ProMax X-ray unit. Select 2D Dental, then Panoramic. In the upper left of the touchpad, choose the patient's size. If the patient size is questioned, it is better to choose the larger size. Press forward in the lower right of the touchpad to continue. Evaluate the patient's dentition and select the appropriate maxillary arch shape and size. Have the patient remove glasses, jewelry, all removable appliances, and hair accessories. Have the patient stand tall, hold handles, and walk close to the unit. To begin the positioning process, adjust height of unit until the chin rest is even with the patient's chin. Instruct the patient to bite on the bite stick, and visually verify the upper and lower anterior teeth are in the grooves. Patient may also be positioned using the chin cup. The chin cup will keep the patient in occlusion. Use cotton rolls to open occlusion if needed. Lower the bite stick so the patient's chin is resting on the chin rest. Verify the cervical spine is stretched by gently lifting up on the back of the patient's head. Have patient smile wide and raise or lower the unit until the posterior occlusal table is at a slight downward angle. Close temple supports. Align the mid-sagittal laser between the eyes by moving the head left or right. While standing to the left of the patient, roll the thumb wheel to position the layer light in the interproximal space between the cuspid and the lateral incisor. The layer light represents the middle of the focal trough. It is meant to intersect the apical region of the upper and lower central incisors. Press forward to continue and instruct the patient to remain still, close the lips, swallow, and suction the tongue to the roof of the mouth. Press and hold the exposure button until all audible noises cease. The image will appear on your computer screen. If your imaging software requires you to save the image, press OK or Done where applicable. Periapical setup. To capture a segment PA-like view, select 2D dental, then panoramic from the touchpad of your Promax X-ray unit. To isolate the desired region of interest, select the radiation symbols. Press forward in the lower right of the touchpad to continue. Follow the rest of panoramic positioning instructions. For information on add or...
Okay, so this was a film about panoramic radiography. So it showed you what I've been explaining using just my presentation. So hopefully this visual was helpful in determination of how to take a panoramic radiograph in clinical practice. So now I would like to share one more little film, and this time about panoramic again, but with a function of auto focus.
To begin, prepare the imaging software until the computer screen says Waiting for Ready. The appearance of this screen may vary depending on your software and version. If imaging in Planmeca Romexis, follow the steps below. Open Planmeca Romexis. Select the appropriate patient. Select 2D module from the menu on the left, or choose Go to 2D Imaging from Next Steps, located on the bottom left of the patient dashboard. Select Panoramic Exposure from the 2D Imaging dashboard, or from the top drop-down menu. Once computers show Waiting for Ready, walk over to the touchpan on the Planmeca Promax X-ray unit. Select 2D Dental, then Panoramic. In the upper left of the touchpad, choose the patient's size. If the patient's size is questioned, it is better to choose the larger size. Press forward in the lower right of the touchpad to continue. Evaluate the patient's dentition and select the appropriate maxillary arch shape and size. Select Autofocus. Have the patient remove glasses, jewelry, all removable appliances, and hair accessories. Have the patient stand tall, hold handles, and walk close to the unit. To begin the positioning process, adjust height of unit until the chin rest is even with the patient's chin. Instruct the patient to bite on the bite stick and visually verify the upper and lower anterior teeth are in the grooves. Patient may also be positioned using the chin cup. The chin cup will keep the patient in occlusion. Use cotton rolls to open occlusion if needed. Lower the bite stick so the patient's chin is resting on the chin rest. Verify the cervical spine is stretched by gently lifting up on the back of the patient's head. Have patient smile wide and raise or lower the unit until the posterior occlusal table is at a slight downward angle. Close temple supports. Align the mid-sagittal laser between the eyes by moving the head left or right. Press forward to take autofocus on the touchscreen and instruct the patient to remain still. Close the lips, swallow, and suction the tongue to the roof of the mouth. Once the autofocus images appear on the touchpad, verify that the red line passes through the root tips of the central incisors. If needed, make autofocus adjustments by moving the arrows mesial or distal. Press forward to continue and instruct the patient to remain still, close the lips, swallow, and suction the tongue to the roof of the mouth. Press and hold the exposure button until all audible noises cease. The image will appear on your computer screen. If your imaging software requires you to save the image, press OK or Done where applicable. Periapical setup. To capture a segment PA-like view, select 2D Dental, then Panoramic from the touchpad of your Promax X-ray unit. To isolate the desired region of interest, select the radiation symbols. Press forward in the lower right of the touchpad to continue. Follow the rest of 2D Panoramic with autofocus positioning instructions. For information on
Okay, so in this video, you could see automated mode for taking panoramic radiography with visible autofocus. So this is one of these things I was mentioning to you, that the technology of panoramic radiography is getting more and more and more advanced and complicated. And in fact, in the case of the film, there was one more thing that was highlighted that I did not tell you in the meantime, which was putting the tongue against the roof of the mouth, against the hard palate. This is very important step. Because if a patient does not place the tongue against the hard palates, then there is some air in the oral cavity, and this air casts a radiolucent shadow like a crescent overlapping the apices of upper teeth. And this makes our diagnosis really difficult. And of course, you also saw in the films that just before the exposure, the patient is also asked to swallow. Because if we don't ask the patient to swallow, the patient might be compelled to swallow the saliva accumulated in the oral cavity during the scan. And of course, at that moment, there will be movement. So motion artifacts will most probably appear in the obtained radiograph, and you would be obliged to take another radiograph. We also ask the patient not to move throughout the exposure, but we don't ask the patient to take a deep breath and stop breathing, because we know that the radiograph lasts for at least several seconds, in some machines maybe like 15, 19 seconds. So for some young patients, for some patients who dive, it's not a problem to hold the breath for such a long time, but for many patients, older patients, patients with chronic bronchitis, with asthma, it might be difficult to hold the breath for such a long time, and they would need to take a breath again during the exposure, ruining the whole radiograph. And we don't ask the patients to close the mouth, to close the eyes. I remember when I was a child, I thought that if I had eyes open during radiography, the x-rays would burn my eyes. But this is not true, of course. The x-rays penetrate through the tissues, but they will not burn the eyes. And even if I close the eyes with a my eyelids. They will not protect me against X-radiation. So the other explanation for asking the patients to close the eyes was to avoid unintentional following the moving object, which is the X-ray tube with their eyes. So we wanted to prevent doing that, but now we don't ask the patients to close the eyes. I think that it's much more scary if you don't see what's going on around you and you keep hearing these strange noises like beeping and also the noise of X-ray tube generating the radiation. Of course, we ask the patient to close the lips on the bite pack. One more thing that was not highlighted in the film, and in many cases it's not even highlighted in textbooks. It's the people with moving teeth, mobile teeth, people who are edentulous or partly edentulous. Of course, these people will not be able to bite with upper and lower incisors in the groove on the bite pack. So for these patients, we use a special chin support for edentulous patients. Sometimes after trauma, we also use the chin support because if a patient suffers from trismus, an infection after trauma, then he or she will not be able to open the mouth sufficiently to bite on the bite pack. Okay, so now I will come back to my presentation. Hopefully it will be also running smoothly. Right, so far we have been talking about the correct patient positioning. Now I would like to talk about incorrect patient positioning. And of course, we started the topic in our seminar the previous Monday. So this will be like supplemental information to the one in seminar. I showed you a seminar picture with earrings explaining that's the right earring produces ghost image on the left side and the left earring produces the ghost image on the right side. But it's difficult to explain, so I added here some photographs from a rather old textbook, but this textbook is like a Bible in oral radiology. And in this textbook, there are photographs and radiographs derived from the cadaver study. So half of human skull was placed in a panoramic radiograph. And you can see already that it's an old photograph, old panoramic radiograph, but on the other hand, I'm not sure if now any bioethical committee would give permission for such a study. So left side of the skull, the right side is empty, it's just the air. So when you take a panoramic, you expect to get the image on the left side corresponding to the skull. But what about the right side? There are some shadows also on the right side. So where do they come from? These are the so-called ghost images. So the images of the structures which in the second half of the rotation of the X-ray tube are outside the focal plane. So they are called ghosts because ghosts do not exist. At least I think ghosts do not exist. So ghost images are images of something that does not exist. So it does exist, but on the other side. And if half of the head of cadaver is placed in panoramic machine, also with soft tissues of the face, now we can see even many more images on the left side because it's ghost shadows of not only the bone, but also ghost shadows of the soft tissues. So I showed you this slide in the seminar as well. So let me go to some other images. So there is some kind of a earring and a ghost image of this earring on contralateral sides. This is a piercing in ala of the nose. So it does not disturb really much in our interpretation, but this is it. This is not a kind of foreign body. But in here, it's also a piercing, but this time the piercing is in the lip. So the shadow of the piercing is cast on the teeth and obscures some parts of these teeth. Again, a piercing in all of the nose, with a lot of piercings in the left earlobe, producing a very, very, very dense ghost shadow overlapping right maxillary sinus. And this patient offered us to take off her bra for panoramic radiography. I think she must have confused panoramic radiography with chest radiography. But sorry, we were not interested. We were just females in the department, and we did not want the patient to take off her bra, and definitely it's not necessary for panoramic radiography. So we took the radiograph, but the patient forgot to take off something else. She forgot that she had a barbell piercing in her tongue. So something like that, which also casts a nasty shadow on the radiographed teeth. This is a necklace, but please remember that although you see it in front, it doesn't mean that this is the necklace in the front of a patient's neck. This is in the back. So this is again the ghost image, but of a necklace on the back of patient's neck. I told you about removable things. Okay, some things are removable, but they are not removed for radiography. And it's mainly because of two reasons. It's not the fault of my radiographers because they remember. It's the fault of a patient. So sometimes patients do not hear the instructions or they do not understand the instructions. So this is one group of patients. And the second group of patients is like very nice looking middle-aged ladies who think that if they take out their removable prosthesis, they will start looking like an old granny. So they leave the prosthesis, the denture in place, and then they think that nobody would notice. Unfortunately, we do notice. That's a pretty bad shadow of removable denture. This is a removable orthodontic appliance. I took this picture in our Phantom, but it's quite surprising that I also could find a panoramic, and not with a single, but with two orthodontic appliances. So this was clearly a mistake of a radiographer. Now, this is hearing aids, and if we ask the patient to remove it for the scan, of course, we will not be able to communicate with the patient very clearly. And in this case, this hearing aid overlaps a little bit the TMJ left condyle. But on the other hand, we must remember that TMJ radiographs in panoramic radiographs are not the best for evaluation of TMJ. So if a part of a TMJ is obscured, it doesn't really matter. I think I explained this one as well in our seminar. If the lead apron without collar is placed too high up on patient's back, then it will produce a shadow, which is called shark's fin. It's like a shark swimming in the water that's just fin protruding out of the water. And in this case, the patient put the whole lead apron high on the back, and this resulted in this very dense shadow. So if let's say the intention for the patient was to protect himself against radiation, to protect himself better by putting the lead apron higher on the back. He completely did the opposite thing because we had to retake the radiograph, and this way the patient received double dose for this exposure. And this is a radiograph with thyroid color, so of course it's useless in panoramic radiography. I did not find any radiographs in our material with glasses, so definitely the radiographers remember that they should not keep the glasses during the exposure. So I took, as you can see, I took a radiograph of our phantom also with glasses. And some patients are just too well prepared for examination, and this patient was unbelievable. I didn't show you this one in our seminar. It was absolutely amazing because when she came for radiography, she offered the radiographer that she would take out her bridge, her fixed denture. And my radiographer was like puzzled because, fixed denture means that this is fixed and you don't remove it for radiography. But the patient claimed that her fixed bridge was removable, and she just took it out. So what you can see here is just the places for the posts for the denture. Like absolutely amazing that the patient did not have any periapical lesions with the constant contact between the oral cavity and the places for the posts in the bridge, the fixed denture. Amazing. Of course, some elements cannot be removed for radiography, and I have already listed some of them in the previous part of our lecture. So it can be a plate for osteosynthesis. It can be a lot of plates for osteosynthesis. So this is a patient after surgery, Lefford 1 osteotomy in maxilla os, and sagittal split osteotomy in the mandible, and also, as you can see here, expansion of the chin, and also has upper and lower fixed orthodontic appliance. And of course, these surgeries are performed to repair gross malocclusions. So definitely it's not possible to remove all these metallic objects until the treatment is over. So this is a patient with cleft palates and fixed orthodontic appliances with palatal arch. So again, it's not possible to remove these devices for the exposure. What you can remove, it's just the wire, the orthodontic wire, but in fact it doesn't really matter if the rest stays anyway. And these are the so-called surgical clips. This is what's used by surgeons after surgeries instead of conventional stitching. So the real images and the ghost images of these surgical clips. This is a radiograph taken in the times when we still had conventional radiography and cassettes with intensifying screens. And because of these lines that appeared in the resultant radiograph, we really thought that this had been the fault of the so-called intensifying screens in the cassette, that they were dirty, so the radiographer cleaned them, wiped them, and the radiograph had to be retaken. And it was very, very surprising that the second radiograph was identical. And only at that time point, the patient admitted that she had had plastic surgery with implantation of some tiny needles in subcutaneous fat tissue for facelift, and these threads were apparently made of gold. So gold is metallic, so gold casts a shadow in panoramic radiography, and not only in panoramic radiography, also in any other radiography. And these are also devices used by orthopedic surgeons in stabilization of cervical spine following especially trauma and maybe also some surgeries. And as mentioned before, also TMJ prosthesis with very, very strong, big a ghost shadow of a prosthesis. So once again, I would like to highlight that, of course, it's not possible to remove the whole prosthesis. And this is interesting. You haven't seen this thing in the seminar. And maybe you remember from the second year the catheterization, so placing catheters into blood vessels and using these catheters to administer contrast medium to demonstrate the blood vessels in the lesions in the body, but also the catheters are used for treatments if there is an aneurysm, like cerebral aneurysm. In this case, individual coils are being released one by one in the lumen of the aneurysm, and they cause blood clotting. And so if there is no blood flow inside an aneurysm, the patient is treated. And in this case, a patient following such treatment, you can see two images, but this is not true. There was just one aneurysm and one place where all the coils were packed, but it was in such a location in relation to panoramic radiograph that it produced two real images, just like also epiglottis produces two real images on both sides of the radiograph. As for patient positioning and other errors, and here you can see incorrect choice of jaw shape and size. So too big radiograph in comparison with small face of this child with milk dentition only. And this was biologically a very big male, but judging from the date of birth, which is input in the panoramic machine, he was considered to be a child, so a smaller field of view was applied, and this way TMJs were cropped from the small image. If a patient is slumped, so like this giraffe with the head tilted forward, then especially in older panoramic machines, one can see the ghost image of cervical spine. If a patient's head is rotated, then one side of the image is bigger, the other side of the image is smaller. This is a common mistake with the chin tilted down too much, so the Frankfurt plane not horizontal. The occlusal plane looks like a letter V. The obtained radiograph like that. Of course, you can diagnose teeth, but you cannot perform any reliable measurements in panoramic radiographs once you remember that the positioning is not repeatable and is subject to errors, technical errors. The opposite mistake And the occlusal plane is tilted up, chin tilted up. So the occlusal plane looks, well, as I'm saying, like the letter W, but it's like a flat letter W. In this clinical picture, it will be better highlighted. So remember, if it's like a W, the mandible looks like a W, it means the chin was too much up. The error, which in some extent is eliminated by these newest machines, like the one I showed you with this S-band technology with parallel layers, it means that the machine can tolerate a little bit of a mistake in positioning. So if the teeth are a little bit too far to the front, a little bit too far to the left, the image will be still clear. But if they are definitely too far to the front, then the image is very characteristic because anterior teeth are like matches. They are very narrow, and instead you see too much of a spine, a temporal bone, earlobes in this radiograph, while the teeth are very, very, very narrow. When the patient is too far to the back, well, it's less common mistake, but it can also happen. Then the incisors are too far to the back and their image is blurred and widens. And this is in fact a patient in whom we were not able to get a good panoramic radiograph. It was a male, about 32 years of age, and he was a victim of COVID. His lungs were so damaged after COVID that he was under ventilation, and he was waiting for lung transplantation. But of course, before transplantation, the teeth had to be treated in order to avoid periapical lesions, which after transplantation, in the conditions of immunosuppression, could threaten his life. So he was transported to us on a bed, on a trolley for panoramic radiography, but he was not able to stand in the machine. He could just sit a little bit, but we were not able to get a good panoramic radiograph in such conditions. So we just supplemented the radiograph with some periapicals. And this is a mistake of one of our trainees in radiography. In fact, he took 3 radiographs like that in the same patient, 3 times the same, 3 times positioned incorrectly, so too far to the back, teeth widened, not visible, blurred, cropped, angles of the mandible. And after having taken the radiograph 3 times incorrectly, he finally came to me for help. And I came, and in the next radiograph you can see that it was possible to position the patient, just you had to do it correctly, and then at least the teeth are visible. And this is the error which results from the air in the mouth. This is what I highlighted, that the patient should have put the roof, the tongue against the hard palate, against the roof of the mouth. And if a patient doesn't do it, there is a crescent of radiolucency overlapping the upper jaw. A collection of motion artifacts, sharp movement in horizontal plane, and it's not a child. It's not a child. We cannot estimate dental age precisely by looking just at the teeth, because humans are not horses, but definitely this is not a child. So in an adult, sharp movement of a head. And this was a child long time ago. Before digital radiographs, we could not see the result until the radiograph had been processed in chemicals. So it's more like an ECG curve than a panoramic radiograph. So then motion artifacts do not depend on patient's age, really. We associate them with children because the children are very mobile, they don't pay attention to the orders, they do not cooperate, but also senile patients, elderly patients, they do not cooperate. So in this patient who during the best years of his life was a very important person in our city. But then when he came to us, he was a very, very fragile, elderly person requiring constant support from a caretaker. And this is one of the strangest radiographs I have ever seen. And this one was taken in a teenager with mental disability, and her mother was so focused on the panoramic radiograph that was needed for dental treatment that she just was supporting the chin of her daughter with her fingers during radiography. And this is not the fault of a patient. It's not the patient movement. It's just the software went crazy when reconstructing the image. And this is probably one of the strangest radiographs, panoramic radiographs I have ever seen. And this one was correctly positioned. So my radiographer thought that the machine was out of order because of instead of panoramic, we got something like lateral cephalometric, but it was the fault of a patient. She was so scared of the machine that she abruptly put her head too far to the back, but so very far to the back that the teeth were in the place where cervical spine should be. That's why we saw just lateral images of the teeth, of the lips, and this strange ghost shadow in the middle. And in order to tell you about the panoramic, about cephalometric radiography, as we have already mentioned the cephalometric and the difference between cephalometric and panoramic, I would like to show just one last film for the end of our lecture today. Let me share the last short film. Okay, so this film at least had nice subtitles to give you a glimpse on cephalometric radiography. So that's the end of our meeting for today. And as mentioned, Dr. Luciana will be back with you next week for the coming lecture. Thank you very much, and have a good evening. And